So how do you find the social psychologist to do the evaluation?
We have social workers that are involved in, can you hear me okay without the?
Yep.
Okay, thanks. That are part of our program that are very familiar with end-stage renal patients. So when they do our psychosocial evaluation at the evaluation appointment, all that's taken into account and they're very attuned to that. We have a psychologist on staff too that we have at UCSF that we refer donors to that is especially attuned to those situations, because there are things that you have to take into account for a donor is why are they doing this? You know, to make sure that they're not being paid, you know, because that's not something that we agree with, or
being coerced in some
or
way.
being coerced, or if there's something that's negative that they're getting out of it. We don't want that negative piece. We want the positive piece, because it's only a problem after the transplant happens.
Thank you.
And so I just want to piggyback and just say, we have social works folks who are under our staff. We don't ask for the social work component to be done by what we would call a general social worker. We have social workers who work with our pre-transplant population, who are the same social workers who work with the post-transplant. So if you saw our social worker Laura Griffin and you did not have a living donor, then when it comes time where you get to RECE, and I'll let the ladies explain what RECE is, you're going to see Laura Griffin saying, okay, when we last spoke, this is what we came up with. And if you have your transplant and you hit post-kidney transplant, who you're going to see is Laura Griffin. How's it going? And Laura Griffin and Sarah Rapp continue with you through the post-transplant process. For living donors, all transplant centers have a living donor advocate. Our center uses a social worker who is the same social worker who dealt with the donors pre this CMS mandate, that we have a title called the living donor advocate. So this social worker sees you pre and also would follow with you post. In regards to a psychiatrist, psychologist, we have someone on staff who sees both the donors, if the social work living donor advocate feels they need to be seen, or if they are what you call, I forgot the word, altruistic, which means I just got a call saying, hey, I don't know anyone on that recipient list, but I want to give a kidney, which happens. Then those folks automatically get assigned to see this particular psychiatrist, because we have to find out what prompted that call. If we have a recipient where the social work team feels they really need to go see the psychiatrist, then we let the patient know you are being asked to go see this person for the following reasons you've stated. So it is a collaborative relationship we have with the patient, whether they be the recipient or the potential living donor, or the transplant recipient with the person who gave the donation.
Thank you.
Oh my goodness, yes.
I have a question about the also medication that you take post-transplant.
Okay.
The reason for it, and when is the best time to take it in terms of your immunosuppressants?
So the question is, what specifically ulcer medication do you take post-transplantation, and when is the best time to take it with your immunosuppressive medications? The ulcer medication that you take is the same ulcer medication that multiple people take now: Nexium, Prevacid, Prilosec, any of those medications. And the pharmacist goes through all the medications with the patient after transplantation, including what time to take certain medications. If people are having certain GI upset, we may change the timing of those medications. They may differ based on different absorption of different medications. So those all get explained very carefully to every patient before even leaving the hospital. And they don't have to be lifelong necessarily, the medication. Yes. The top three, what are the top three adverse outcomes that occur with this operation? The very bleeding and wound healing, I mean, maybe 1 to 4%. Urine leaks, 1%. They're very rare. But they happen, but when you see enough of them, you know how to treat them very easily. So they are complications. There are things that the patient needs to know exist, but they're certainly we're able to recognize them right away and treat them appropriately.
So it's a fairly routine operation?
It is at our institution, we've gone greater than 9,000 of them. Yes.
What's the symptom for rejection?
The question is, what are the symptoms for rejection?
Yeah, so the patient can call it.
Great question. The answer is none. And that's the reason why we have to get your blood work done so frequently right after a transplantation. The only times you're going to have symptoms of a rejection is if you've decided to stop taking your medications for 3 weeks and all of a sudden your body is full on attacking the kidney. You might get pain in the side of the kidney, bleeding in the urine, fevers. But if you're taking your medications, rejection can happen subclinically, meaning no change, you feel great, but we start seeing your creatinine trending up a little bit. Then we get a little nervous. We start seeing that your creatinine went down to 0.8 after transplant. Next time we see you, it's 1. Next blood test, it's 1.2. Next blood test is 1.4. That's when we know something is going on in the kidney transplant, and we have to do a kidney biopsy to look at it. But there are no symptoms, and that's part of the reason why we see you so frequently after kidney transplant. Well, the question is, after several years, how do you know if they're having rejection? It's the same thing, because we still get your blood work done frequently. We still want to see that blood work done even 2, 3 years after transplant. We still see your blood work coming in every month, every 3 months. And we start to see those trends, we give you a call and say, look, you're trending in the wrong direction. We want to see you. Come to clinic to see us. Yes?
Once you have a transplant, is it automatic to get a biopsy yearly?
Great question. Once you get a transplant, is it automatic to get a biopsy yearly? Actually, it's automatic now to get a biopsy at 6 months. So that's a new thing. Those are called management biopsies. So the reason for that is because of her question, which was sometimes even your creatinine is perfect. Nothing's happening. You look great, blood pressure is perfect, kidney function looks perfect. But we've noticed that some people still will go on to have a rejection. So what we do at 6 months is we look under the microscope at this kidney biopsy. Sometimes we catch early rejection because a significant amount of damage has to happen to the kidney before the creatinine starts to rise. So we want to see, well, what's going on in this kidney that's not being reflected by the creatinine? So we do a management biopsy for all patients, and this is relatively new, at 6 months, and we've caught some early rejections. So we know, this person needs to be maintained at a little bit of a higher level of the medication because they had some activity going on in the kidney. So yes, 6 months. Yes, sir.
There are lots of dietary restrictions when you're on dialysis.
Yes.
Are there any same kind of restrictions after a transplant?
Okay, the question is, there are lots of dietary restrictions in kidney and end-stage patients on dialysis. Are there any restrictions afterwards? Very good question. And the answer is yes and no. So there are multiple changes that happen after transplantation. So you guys are going from you can never touch potassium, right? I mean, you haven't had a banana in like 10 years, right? You can't touch potassium, you can't have your oranges, you can't have your spinach, you can't have your tomatoes and your potatoes, and your phosphorus is very high. So you gotta take Renagel and Foslo and Fosrenol, and you can't have your dark sodas, and you can't have your cheese. Many of those things do change after transplant. So before, your phosphorus is gonna be high. After transplant, we see phosphoruses plummet after transplant. We send people home, we want you to have diet soda, we want you to have cheese. I mean, they're like in heaven, Potassium is a little trickier. It's a little trickier. Usually, patients can have a normal potassium diet after transplant. The only reason I say it's a little trickier is because some of our medications can cause high potassium levels after transplant too. And so sometimes we want our patients to kind of still back off a little bit on the potassium-containing foods. Usually that's only for the early post-transplant. So other than that, dietary restrictions are essentially completely gone. We don't want, if you're diabetic, we don't want you, eating, high sugar foods and blood pressure. Depending on what your blood pressure does before or after, we may encourage a high salt diet after transplant. We may require still a low salt diet after transplant. It's very different, and it's based on the individual. Yes?
What is your feeling regarding the generic transplant medications?
Right now, several institutions, including Kaiser, all of our Kaiser patients that we take care of are on generics. We feel they're just as good as a non-generic medication.
Have there been any studies done regarding generic versus brand?
Have there been any studies done generic versus brands? Not that I'm aware of. Yes?
I've heard of several transplant patients at CPMC who started the generic program and the creatinine started spiking. And what I was told, and correct me if I'm wrong, is that it's harder to manage the levels with the generics. And they were taken off the generics and told never to go back on them.
The question is that several patients that she knows about CPMC were placed on generics, their creatinine started shooting up and they were told to go off of it. These medications are metabolized by the liver. They are, in other words, and every person is very different in terms of how they break down that medication, how that medication reacts with them, how that medication works with them. And so some people may break down that medication, the generic, very differently than the non-generic medication. And one person might require 10 milligrams of Prograf, and another person might require 2 milligrams of Prograf. So it's very hard to say whether it's something specific to the generic formulation or whether it's just that that person is metabolizing the medication differently than they metabolized the original. And we watch for that. I mean, some insurance companies are only paying for generics. I mean, there's nothing we can do about that. We watch the patients very carefully, and we do insist on Prograf specifically or cyclosporin non-generic formulations if they have any issues. I personally have not seen any problems, but I know that other people have. Yes.
In the event a patient is not considered right for a transplant and should continue with hemodialysis, is that patient, does UCSF follow up with that patient by blood test to see how they're doing?
Can you answer that?
Do you have a, no?
Well, I mean, if you're initially deemed not to be an appropriate transplant candidate and we tell you why. So let's say you're not a transplant candidate because of A, B, and C. If you later on have resolved the issues A, B, and C that we tell you about, you give us a call and we'll reevaluate you at that time.
Thank you.
Yes, gentlemen, back.
What's the latest statistics on transplant lifespans?
In general, it's a huge range, but in general, for living donor transplants, we see lifespans or the life of the kidney. We see with living donations, 15 to 20 years on average is a lifespan, but we see patients who lose their kidney after 3 years, and I've seen patients who have a kidney for 35 years. And cadaveric donation will be anywhere from 10 to 15 years, but again, depending on comorbidities, other illnesses that the patient has, if they're compliant with their medications, that really alters the lifespan of a kidney. But I've seen patients 35 years with a kidney, 40 years with a kidney. Yes?
Question, in keeping with what he just said, okay, so let's say hypothetically someone does receive a kidney and after 3 years, that new kidney, gets 86, it's just not healthy anymore. What happens at the next stage? They'll go back onto dialysis and then have a transplant? And then, I guess at that point, would you have 4 kidneys in your body, or how does that work?
The question is, if your kidney fails, your kidney transplant fails after 3 years, what happens afterwards? Do you go back on dialysis? Well, you can go back on dialysis. If you can also be reevaluated while, if your kidney reaches that GFR less than 25 or 20, we will reevaluate you. You can certainly get another kidney transplant. And the answer is yes, you have 4 kidneys. Sometimes you see 5 kidneys. Oh, yes. Go ahead, Deb. Did you want to say?
I just wanted to say that you've been exposed to a foreign object because of that previous transplanted kidney. So it's very important that we follow your antibody level for a second transplant. It may be increased.
Right, exactly. The cross match that I mentioned, you're higher likelihood of having a positive cross match because you've been exposed to kidney, those proteins, those molecules before, and so therefore your immune system is sort of more revved up than somebody who hasn't, and therefore you're more likely to have a difficult time getting another kidney. Yes, sir. The question is if a patient who's a kidney transplant recipient, the kidney is doing well, but the patient dies of trauma, is that kidney available for donation? And the answer is no. Question was going, go ahead, let me finish, you finish your question.
Yes, can you grow extra toes with a stem cell? No,
Oh,
not
that's not the question I thought you were gonna ask.
kidneys. Can you grow extra kidneys?
Not yet, no.
Not yet, but how soon? Maybe.
I'm working on it.
Check back next.
I don't. Yes. So the question is, if you have a person who is obese and therefore not a candidate for transplantation, do you go ahead and test the donor under those circumstances?
The administrative answer is it really depends on that recipient's insurance. If the living donor would like to use their own insurance, then that would be something we would take into consideration. But all living donors are processed through the recipient's insurance. So the recipient's insurance, they may get lucky and they'll say, yeah, go ahead, this person's vowed on every planet that they're gonna lose the 40 pounds or whatever. Or you'll just say no, when that recipient is considered through your program as a candidate, then we'll process the living donor.
And from a clinical standpoint, if we would take this posture and screen and do the cross-matching with your donor today, and then it took 6 months for you to get to goal weight, we would need to re-cross-match you again in 6 months because you may have developed some antibody response that can alter the cross-match.
Or the donor.
Or the donor may have a change in their medical status where it can influence their ability to donate.
I was going to say, we'd also like to give an incentive to the recipient to start losing the weight because that's a real emotional thing and it's hard for them to lose it, especially if you're on dialysis or PD especially. If you say you're going to wait till you achieve that goal weight, then it gets them going a little bit more too, rather than, well, I'll just wait until later.
And just so you know, we do have one of our transplant surgeons, Dr. Postle, does do bariatric surgery. And so our patients who are not deemed transplant recipients because of obesity have been referred to him on occasion for that surgery. He's an expert in transplant as well as bariatric surgery. Yes.
A follow-up based on the answers you just gave. Everybody's concerned about the insurance. Will the insurance pay for it? But how much would it cost to evaluate the donor if, for instance, the person donating or the recipient was prepared to pay cash?
The preliminary immunogenetic testing, the HLA, the antibodies, the cross-match, the last time I gave someone who asked me that specific question, it was a quote, I would say a few months ago, of over $2,000. And that's just to find out if you're a candidate. And so
it's not that much. They don't have to be
No,
terrified.
that's just the testing to say, yes, I'll start working on you.
Yes.
Then you have the whole diagnostic, the medical. You're talking about an extensive amount of money. Where, again, the donor, to quote Bill Cosby's book, I'm not sick until a white coat tells me I am. I have had many, many donors think that they are in perfect health. And once they start this process with the coordinators, they find out they're pre-diabetic. There have been cases the day of surgery find out they're pregnant. It's happened twice in the past couple of months. Or they themselves are unaware they have chronic kidney disease. So the question then becomes, where do you stop? Because you want it with an insurance company, you can keep going on until the insurance company says, okay, you guys, can you really fix this donor for transplantation, or is this an automatic cutoff? And that's when we take it to selection. But if it's a self-pay, these diagnostic tests, like even CBC, lights, things you guys are going to go in for or have gone in for. Have you ever looked at your bill and it's close to $1,500 for 3 tubes?
Yeah.
And if you're self-pay, that's 100% payment. It's not like the institutions are saying, okay, we'll give you a 70% discount. it's, once you start this ball going, it's very hard to then say, oh, I no longer have money to pay for this. You guys need to help me. And that's why it's with living donation, again, this is optional to that patient. And when you say to that patient, look, we've encountered X, Y, and Z, you need to go find somebody to help you, or you need to get into primary care, you need to take care of yourself. Usually you'll have, unfortunately, because it is such an emotional process, you'll have the recipient saying, why can't you fix it? And it's like, it's not for us to fix. This is general health problems that need to be addressed before they can, because of their personal health. So it's a very emotional thing with living donation, which is why if the recipient is not considered a candidate, we rarely proceed with the donor. Because again, you never know what you're going to encounter with that donor. There are many, many folks who think they're healthy, and it isn't until they go in and see a doctor and get basic blood tests that they realize that they have high sugars, that they have all these other generic, what we call generic medical problems that we can walk around with and never know we have.
Yes, sir.
What is the cutoff in terms of being too obese to have the surgery, or what is the goal weight?
Okay, we have certain BMI cutoffs, body mass index cutoffs. There's a chart that looks at height and what your height, what your weight should be. If you are a non-diabetic, your BMI cutoff is 38. If you are a diabetic, your BMI cutoff is 34. We base it on BMI. So there's a chart of how, so they're both within the obese range, and there still are cutoffs. But
A second question, I'm confused about the difference between a generic drug and a non-generic drug. Why, if it's designed to do the same thing, what's the difference?
I'm confused by the difference between a generic and non-generic drug. I'm sorry.
Other than cost.
Other than cost. I'm confused if they're designed to do the same thing, what's the difference? The way they're made, the formulations, there's other things in every drug besides just that pure drug in order to make the capsule, in order to make the tablet. They come with all different moieties, they're called, and they have different bioavailabilities, meaning the metabolism of that drug might be different. Understandable question, but that's the way that drugs are made. There's other stuff in those drugs besides the drug that's keeping it in the tablet or capsule form. That's the best answer. Yes?
Could you please speak more about the stem cell research? And what advances are being taken place in other countries as opposed to ours?
Okay, so can you speak more about stem cell research? So the actual question that I actually thought he was going to ask about stem cells and is more about stem cell transplants. I could talk to you about other trials that have happened within this country and what they're doing in other countries with regard to stem cell transplants. In terms of stem cell research, specifically in terms of creating a new kidney or making a new kidney, I'm not aware of that research. I know that there's been recent research in making new cardiac myocytes, so heart cells that are being grown and over a scaffolding growing to create a new heart. So I know about that. I don't know about stem cells turning into or creating new kidneys. So I don't know the answer to that. The question I thought was going to be asked was stem cell transplants as they relate to kidneys. So I can talk about that briefly because that's interesting field.
Please, yes, please do.
Okay, so, I get this question asked a lot by potential recipients. They've looked at the news and they saw, well, somebody got a bone marrow transplant or stem cell transplant at the same time as they got a kidney transplant, and now they don't have to be on any immunosuppressive medications. So that trial was done in Boston, Mass General. They looked at multiple myeloma patients. So patients who have multiple myeloma, which is a bone marrow disease, oftentimes develop kidney disease. So those patients need a bone marrow biopsy, a bone marrow transplant or a stem cell transplant because of their multiple myeloma. And the study that was done looked at 5 or so patients, I don't remember exactly the number, but a very small number, who had multiple myeloma and needed a bone marrow transplant. At the same time as getting a bone marrow from their donor, they got the kidney from the donor. The same donor gave this recipient both their bone marrow and their kidney. And now they don't need to be on any immunosuppressive medications. So why do they not need to be on any immunosuppressive medications? Because your immune system, your white blood cells are made in your bone marrow. So that if you're taking the same bone marrow and kidney from the same person, that bone marrow, your bone marrow is no longer yours. You get that wiped out and you get someone else's bone marrow. That bone marrow with those white blood cells is not going to see that kidney as being foreign because it's their kidney. So that person doesn't need immunosuppressive medications anymore. And there have been some trials also looking at non-myeloma patients who had really serious side effects from the medications getting bone marrow transplants. This is all very experimental, and a bone marrow transplant makes a kidney transplant look like a walk in the park. I don't know if anyone has ever seen someone getting a bone marrow transplant. It is a big deal. It is wiping out someone's bone marrow, their immune system. So that is very experimental. But that's something that's new and perhaps, maybe, more happening more in the future. Other institutions, elsewhere in other countries like India, they do what's called a desensitization program, where what they actually do, which is sort of interesting but very controversial, is that they transfuse blood from a potential donor to a recipient, okay? So you would think that's exactly the opposite of what you want to do. I just told you that getting blood from somebody might sensitize you, might make you develop an immune response. So why on earth would you want to do that? Where their goal is, give patients blood from a donor, then let that donor develop a huge immune response and then wipe it out. So the goal would be, let's let those cells that are going to attack that donor, they'll generate, they'll become a lot of them, and then we'll give them medication to wipe them out, as opposed to leaving a few behind, that can eventually cause a problem. Again, it's very, very experimental. The medications that are being used are very, very toxic. One of those medications is called bortezomib. It's actually coming up and new in transplant. It's also called Velcade. It's used for multiple myeloma, actually. So there are things that are going on in other countries. We may, and we are in touch, we may start some of these trials here as well. It's all part of UCSF is really the development of new drugs, participating in new studies to make transplantation better. So I hope that answers your question. Yes, sir.
A few months ago, there were news stories about an artificial kidney. I think it was being developed at UCSF. How does that fit into the future of transplant?
But the artificial kidneys is actually a dialysis machine that's implanted in the person. So it's a 24-hour machine that is connected to the artery and the vein similarly. That's meant to be a 24-hour dialysis, essentially. So it takes our spot in the body, takes up our spot.
I think we're going to move on to the next speaker now. Fortunately, Dr. Weber and her colleagues will be here after, during the social hour portion, and so they will be available to answer any questions one-on-one that we didn't have an opportunity to have answered right now. So I'd like to thank Dr. Weber. And her colleagues Linda Murkowski, Deb Teege, and Martha Rellis.